Good morning. Hopefully the 5 minutes gave you a little bit of time to get some water, get some coffee, check emails, etc. Um, so the second presentation is going to focus on the Brain Trauma Foundation guidelines for the care of infants and children with severe traumatic brain injury. And I am Dr. Monica Vavilala, and I am the director of the Injury Center here for those of you who are joining in a little bit later. And I've been interested in traumatic brain injury work for nearly 2 decades, focusing on understanding cerebral physiology, understanding in-hospital care processes, and how those two relate to improving outcomes. My initial work focused on cerebral blood flow and autoregulation, and we then expanded to working in the area of looking at guideline adherence and outcomes. So it's my pleasure to be here with you today. And I serve on the Brain Trauma Foundation Guidelines Committee for Adult and Pediatric TBI. It's been a very interesting experience to get folks together, clinical investigators together, to try to come to consensus on how we ought to be treating these children. So I'm looking forward to sharing some of that information with you today. My practice is at Harborview Medical Center. It is the only level 1 adult and pediatric trauma center in the Pacific Northwest, covering Washington, Alaska, Montana, and Idaho. And these are a little bit dated numbers, but similar to what we had last year. Our total trauma admissions are over 5,000. They're probably 6,000 last year. We are comparable to Baltimore shock trauma in terms of our numbers. Our pediatric numbers are, you can see here, we take care of children too, and many of these kids are admitted with injuries from falls. We are a burn center, and then these other mechanisms. So what I want to talk about today is really a little bit about the TBI burden, some of which you heard from Dr. Rivara, the evidence-based guidelines, and the pediatric guideline adherence and outcomes program that we started here at Harborview Medical Center in 2015. And I'd like to share with you some of that data. So this is the CDC breakdown of unintentional motor vehicle traffic injuries and how common they are, and that the top 2 leading cause of unintentional injury deaths across the lifespan. Very significant problem, and one that requires continued efforts in all our public sectors. In 2008, the World Health Organization and UNICEF report on child injury prevention reported 1 million pediatric injury deaths a year. And this is probably an underestimate, given that many countries don't have a good reporting system. And because of our trauma systems here in the United States, and because of injury prevention efforts, the number of deaths in the United States has actually reduced significantly since 1980s. The problem is it's still growing dramatically in low middle income countries. In fact, the estimates are there's one severe pediatric trauma every 6 to 9 minutes worldwide. That's staggering. And the leading trauma is traumatic brain injury, making this not only a local but a global problem to deal with. In the United States, the medical cost, work loss cost for families who have to take care of kids with severe TBI, and the combined cost is extremely large. And daily, we have 133 people dying from TBI. Falls is the most common cause of TBI, but in fact, over 50% of TBI deaths are from motor vehicle crashes. So falls and MVCs still are a big problem. This map here is from the CDC website, and it shows the mortality rate for pediatric traumatic brain injury. You can see here there's a lot of variation, and one of the themes for this presentation today is going to be variation, because that is something we want to reduce. We want to understand best practice. We want to understand how to reduce the high mortality rates and the high poor outcome rates, and kind of have this map of the United States be a little bit more homogeneous. So let's start with what is a TBI. the CDC defines this as caused by a bump, bolt, or a blow or jolt to the head that disrupts normal brain function. And the severity can range from mild to severe. Now, clinicians define severe TBI using the Glasgow Coma Scale score. There are different classifications, but I think the idea here is that if you have a mild traumatic brain injury, you have a brief change in mental status or consciousness, as opposed to severity, where there's an extended period of unconsciousness or memory loss after the injuries. It's important to remember that not all blows or jolts to the head result in a TBI, but the more severe the mechanism is, the higher likelihood of having a severe traumatic brain injury. The population burden is from mild TBI, also known as concussion. Some of it may be sports related, some of it may not be. But and we're just now really starting to understand what are some of the outcomes, long-term outcomes after mild TBI. Nonetheless, this classification is important because it has implications for triage of patients from scene to care, and also the kinds of capacity that health systems need to have to care for children with severe TBI. So the typical classification is phenotypic, meaning we evaluate a patient either at the scene, in the ED, or in hospital, and we use this Glasgow Coma Scale score to say, well, are you a 3, 4, 5, 10, 11, 12, 15? And this is the traditional classification. 3 to 8 is severe, 9 to 13 is moderate, and 14 to 15 is mild, although I will say there's some emerging conversations suggesting that the GCS of 13 or the GCS of 13 really, this should be, the mild category should be 13 to 15. Some folks feel that the Glasgow Coma Scale score of 13 really belongs in the moderate category because they have more impairment than patients who have GCS of 14 and 15. This is why I have sort of classified it as such, although you will hear some folks argue that GCS 13 should be mild TBI. But again, this is an area of controversy. This classification is really important because the initial triage and treatment is based on clinician assessment of GCS. Of the GCS types, which the subcategories of eye, verbal, and movement, the post-resuscitation GCS motor is most predictive of poor outcomes. And important to remember this GCS score is modified for nonverbal children for crying and other things, so that there's a difference between the adult and pediatric GCS scoring subscales. So one main important point I want to sort of make here is that it really does take all of us to take good care of the severely injured child with traumatic brain injury. Because we encounter these patients at different times, we bring our expertise, and I'd say nursing and pre-hospital providers are really critical to sort of keeping, being the hub for the care of these kids. Typically, if a child has a mild TBI, they're triaged or transferred or brought by pre-hospital providers to a non-trauma center. They could be seen at a trauma center. They could also be evaluated and treated at a community hospital that has no trauma designation. They could be seen at a clinic. If you have a moderate TBI, our data, this is not published, but we're just submitted this for publication. Almost 30% of the kids with moderate TBI are actually receiving care at non-trauma centers. And we don't know if this is appropriate or not appropriate yet. We're in the beginning of this investigation, but if they have poor outcomes and some of them deteriorate in hospital, they really may need to be taken care of at a trauma center, a high-level trauma center, because they then fall into this category. So what I'm trying to elucidate here is that these classifications of mild, moderate, and severe are kind of, they're typically made at admission, but there's a continuum, and patients who have one TBI severity when assessed at one period of time may actually transition in and out. So if we're, as clinicians or at health systems, taking care of kids with moderate TBI, I recognize that some of them will deteriorate and will have severe TBI in hospitals. So one landmark paper I do want to talk about here is head CT decision rules. This is a Lancet paper published in 2009. This is important because, like Washington State, those of you who are not from here can look at your Department of Health websites where, people are really starting to recommend judicious use of head CT. So if you don't have mental status changes, if you don't have a non-severity mechanism, the trend is moving towards not routine imaging of kids who are otherwise look normal, and this is to reduce the radiation risk. The Washington State Department of Health has a really wonderful explanation of these of when head CT should be performed for the evaluation of children with traumatic brain injury, and I just want to direct you to there as well. So let's talk about a patient. This is a patient who I took care of, and we'll move towards talking about the guidelines. This is a 4-month-old male with a subdural hematoma who presented to Harborview for emergent craniotomy, and I happen to be the anesthesiologist next up, if you will, to take care of this patient. And the story was that this baby was found by grandmother vomiting, was taken to a local hospital, intubated at the Index Hospital with a 4.5 uncuffed endotracheal tube, and had intractable seizures that seemed to be controlled with benzodiazepines. The patient had a right pupil that was dilated, and the baby received mannitol. And I think appropriately and consistent with our Washington State Department of Health transfer guidelines, the patient was transferred to our level 1 pediatric trauma center. And what worked really well for us was we knew this patient was coming. The ED spoke to the operating room. The patient spent less than 5 minutes in the emergency department because what this baby needed was a decompressive craniotomy, and there was no, it was urgent, that it was an emergent. We shouldn't really delay this. So this is what the admission head CT looked like. You can see the subdural hematoma here taking up space, and you can see this midline, and there's shifting. This is the ventricle, and this is shifted over. And there seems to be really loss of gray-white matter differentiation that you typically see on a CT, again, indicating severe TBI. And this I described to you as the anesthetic course, but you could imagine this kind of a scenario occurring in the ED or in the ICU as well. I'm an anesthesiologist, so I'm sharing my clinical experience here. While the surgeon's working on the decompressive craniotomy to relieve the subdural, we're taking care of physiology, making sure the patient is alive. And it was really hard to do in this case. The patient was very acidemic, high lactate levels, bled a lot, had a low hematocrit. And despite, transfusion, the baby had a VFib arrest and underwent needed CPR, was hyperkalemic. And the bad stuff, the recommendations that are in the guidelines in terms of what not to do, we encountered. So unwanted hyperventilation. The patient was cold, and the patient was also very hyperglycemic. We had other problems. Poor vascular access. There was a huge leak because the tube was uncuffed. There was significant hemorrhage, and these are all what we call secondary insults to the brain. So you have the initial injury, and then you have these other things happen that worsen the injury, lead to more cerebral ischemia and more poor outcomes. And unfortunately, the surgery was successful in the sense that the subdural hematoma was evacuated, but the patient expired on the day of surgery 1 hour after arrival in the PEDS ICU from a refractory VF arrest. As some of you may be suspecting, the patient had multiple rib fractures, left femur fracture, and was diagnosed with having abusive head trauma. So what I've described to you so far is the patient, and there's a lot of variability in how patients present. There's also variability in how patients do after they have severe TBI, and this is a study that we conducted here looking at 30-day in-hospital mortality, and you can see, if you look at the region, some of you are from very far away, some of you are here from, in Washington State. There's variability in terms of how patients do after severe TBI. And in the Northeast, outcomes seem to be better. Maybe this is due to rapid transport to a trauma center. We're not quite sure, but the worst outcomes are really here in the South and the Southeast, followed by the Midwest and the West. And so I think we have a lot to learn from what's happening in the organizational context, triage context, et cetera, treatment context in different regions of the United States. There's also variation in discharge to rehabilitation. So if you say 1 is the relative risk of being discharged to rehab, which is what the goal is, you want patients to receive rehabilitation, it's not equal all across the country, and this is because there aren't enough rehab facilities. This is because the rehab criteria aren't clear. This is because people don't recognize that early rehabilitation is good. So again, some variation here. So the intent of the TBI guideline process is to really provide recommendations on standardization of in-hospital care for kids with severe TBI. The first edition was published in 2003. It was then revised in 2012. And I will tell you that we are getting ready to publish the new recommendations, which are scheduled to come out in 2017 towards the end of the year. So what happens is there's a team, an evidence-based review team. We review the evidence, we update it, and then this should say 2012, not 2016, sorry. And then we have it reviewed by national policy bodies and other peer reviewers, and then we publish these findings. So the 2017 update is really a work in progress. And there are representatives from all over the country here on this guideline, and representing different specialties, physicians, nurses, and other investigators who are a part of this. Again, national representation. So the evidence that we considered for development of the guidelines are that you should be under age 18 years. You should have TBI. Your GCS should be 3 to 8 or under 9. It's the same thing. And we want this to be multidisciplinary. So different perspectives. We wanted this to be a living document. We review the evidence in more real time than we did initially. And some of the recommendations are rooted in strong evidence, and some of them are rooted in expert consensus because of the absence of data. So in 2003, there were 18 chapters. The problem was here there were no standards, so no level 1 RCTs that were, conducted to result in level 1 recommendations. 4 guidelines were at the level 2 level, primarily from cohort studies, and then 14 options. So clinicians could consider these options. There were level 3 recommendations because the strength of evidence didn't suggest that those recommendations belonged in a higher level of recommendation. So what I want to show you here is the current state. This is today. We're following the 2012 guidelines, or this is what's out here. So compared to 2003, the SBP recommendations were deleted. Some people argued that really we needed a systolic blood pressure definition because early in the care of these kids, we don't have cerebral perfusion pressure data. Unfortunately, the strength of evidence didn't allow us to put something in here. So my personal recommendation is that we use 70 plus 2 times the age as the ATLS guideline recommendations, because we didn't provide one for use. ICP monitoring is recommended at the level 3 level for GCS under 9 or less than or equal to 8. Cerebral perfusion pressure, the recommendations are to maintain them at or greater than 40. We also recognize that there was probably an optimal CPP somewhere between 40 and 50 across the age spectrum, but we are not able to specify what that should be. But I will say that if we were able to achieve this, a CPP of greater than or equal to 40 for our kids with severe TBI, that would be really great. We don't want to hyperventilate kids because that causes cerebral ischemia. So there's some recommendations on keeping PaCO2 greater than or equal to 30. We want to maintain oxygenation either via bag mask valve or tracheal intubation, depending on what phase of care the patient is in. If advanced neuromonitoring is used, our recommendations are to maintain PbO2, which is brain tissue oxygenation, greater than or equal to 10 millimeters of mercury. And there weren't really good recommendations in the 2012 guidelines on glucose and nutrition. What we are currently drafting language for in the 2017 guidelines is to recommend early nutrition. We're not able to really talk about glucose early versus not because of the strength of evidence. I can tell you our current practice is not to just routinely give glucose in the first 48 hours unless the patient is hypoglycemic, which means we need to be testing for glucose, particularly in babies who don't have good reserve, but that we are aiming towards timely nutrition start, whether that be enteral or parenteral. We are not prophylactically cooling kids anymore because the trial showed that it didn't work. We also want to prevent fever of temperature greater than 38 in these kids because we know that hyperthermia is associated with poor outcomes. Steroids are not recommended, and this is actually a level 2 recommendation, unless, and we added this language, or we're going to be adding this to the 2017 guidelines, unless they're deficient. Now, we're not always testing patients, but the centers that do test for cortisol deficiency. If those patients are deficient, then we are recommending replacement only in that circumstance. The barbiturate chapter recommended barbiturates for refractory ICP, but you have to be hemodynamically stable, and we need to be doing continuous arterial blood pressure monitoring to really use barbiturates in a meaningful way. The 2017 guidelines will recommend specific recommendations about thiopental because those data are very old, but retain some of the content here. Decompressive craniectomy has, I would say, fallen a little bit out of favor. As a first-line therapy, second-line therapy, it's considered by clinicians if you have refractory ICP or if there's deterioration or herniation at the level 3, as a level 3 recommendation. Hyperosmolar therapy is recommended as a level 2 recommendation for ICP greater than 20, with a dose of 2 to 5 milliliters per kilo over 10 to 20 minutes. We are really discouraging routine head CT after the, as a matter of routine practice after admission and initial diagnosis, after 24 hours after admission, because of the radiation risk. So there really needs to be some justification for this. CSF drainage is really dependent on what, the institution that you're at. It is an option for refractory ICP, either EVD or as a lumbar drain, although I would say most people are using EVDs and not lumbar drains for CSF drainage when they're draining the CSF, provided that the ventricles will allow you to do that. We don't really have good recommendations on sedation. The 2012 guidelines called for pentothal or etomidate for high ICP. I think there's a lot of equipoise and opportunity for work looking at the best sedation for ICP. And then, there's equipoise around whether we should be using levetiracetam or phenytoin for seizures. So in terms of the seizures, now this was a question that was asked of Dr. Rivara on the previous talk. We are recommending either of these to prevent early seizures. There's no good data that it prevents late seizures. Now, there are other best practice recommendations that are not in the guidelines, but I feel compelled to mention to them, which are, we really ought to be trying to get patients to the CT scanner within 30 minutes of arrival, because we need to know if they need surgery or not. We need to know how sick they are. Evidence suggests we should be conducting blood alcohol and urine tox screens in kids over age 12. We're not regularly doing that. ETCO2 monitoring should be a standard monitoring, guideline, and we should be aiming for normocarbia unless there's evidence of herniation or impending herniation. We should be aiming for ED length of stays less than 2 hours so they can get the advanced care that they need in an intensive care unit or an operating room. Of course, if it's an emergency craniotomy, they need to really be, discharged to the OR pretty quickly. We need to develop good checklists, I think, and we need to make some recommendations around that. I think the ICUs are really good around the country about monitoring when they're in the ICUs, but when we're transporting patients from the ICU to other locations, we need to continue that same level of intra-hospital monitoring, including ICP monitoring when those are placed. And then early rehabilitation. And then for those families who don't speak English, interpreter services and early engagement with social work probably all together constitute other best practice recommendations. And so even though we think this, and we've had these guidelines, data suggests that there's large variation in how often ICP monitoring, as an example of key performance indicator of care, is done across centers. So adjusting for injury severity and type of injury that we have, ICP monitoring tends to be less common in infants than in older children. And in fact, compared to adult centers, adult centers, pediatric center hospitals tend to perform less ICP monitoring. And this was quite surprising to us because we thought it would be the other way around, but this may have to do with more exposure and use of ICP monitoring in adult patients. So if you receive care at a mixed facility, you're probably receiving more ICP monitoring than a pediatric-only facility. And then there's some really interesting data that, how you design your pediatric neurocritical care unit, which is really an emerging field, is associated with better guideline adherence. So this is a Lancet study published showing the probability of ICP monitoring when you develop a pediatric neurocritical care unit, and it's clearly higher after program implementation. So the center variation that I talked about here, this is a study that we did looking at 5 centers, and you can see the overall survival rate was 87% for very similar patients, but there's variability in survival. And there's also variability in guideline adherence rate. This is pre-hospital, ED, OR, and ICU. So there are opportunities, again, to adopt guidelines and reduce that unwanted variation. And this is important because in this study, we found that there's overall a 6% decrease in mortality with every 1% increase in guideline adherence rate. So the guidelines are effective. And I think there are many reasons why people don't use the guidelines, but they work. And they work in kind of, we think, a dose-dependent manner. So the better you adhere, the better the survival. And these data are shown here. Again, you can look at one as the reference group. Your survival, this mortality decreases, and Glasgow Outcome Scale improves with higher adherence rates. So specific key protective indicators are avoidance of pre-hospital hypoxia, use of mannitol or hypertonic saline in the operating room. Believe it or not, many ORs don't have these available. This is a problem. Maintenance of cerebral perfusion pressure as recommended, greater than or equal to 40 millimeters of mercury. Timely start of ICU nutrition within 72 hours of admission, and not prophylactically ventilating people. These are all critical, and they drive the relationship between guideline adherence and outcomes. And if you're asking the question, does guideline adherence cost more money? It does not. There's no difference between these dollar values, but the guideline adherence, you can see that 92,000 for 50%, 100,000 for higher adherence rates. These are hospital costs, these are ICU costs. So it's really about workflow and organization. But we don't always do it. And the data would suggest that there are clinician barriers, guideline barriers, institutional barriers that we need to overcome. Degree of collaboration between services. People don't believe the guidelines work. We don't know what the guidelines really say. And frankly, some of the guidelines are not easy to digest. So we're working on that. But what families tell us is that they really want family-centered care after pediatric head injury, focused on, they want the providers to get along, first of all. Some of you may be smiling right now. They want communication with their providers, and they want communication between teams. They want to learn how to take care of their children, and they want care coordination. So this is a study that we published a couple of years ago, and I think adds a lot of insight into what should go into a program. So I just want to spend the last few minutes talking about a program that we developed at Harborview called the PEGASUS Program, Guideline Adherence and Outcomes Program. And our goals were to increase TBI guideline adherence, to improve communication between families and providers, to decrease non-value added time, and to improve outcomes. So this is what goes into the program: the protocols, which is the guidelines, the PEGASUS study findings, the stakeholder perspectives. We've integrated the program into our hospital QI metrics, and we revise these annually. We had a lot of kumbaya moments. We had to get along. We had to get to talk to each other. The nurses were critical to making this work. They wanted paper packets, pathways. They didn't want to do things on the computer. And every patient who is now admitted to Harborview with a severe TBI diagnosis is put on the pathway. And the pathways get used by the nurses, and they provide us with wonderful information on what works and what doesn't. So we have 93 patients adopted on the pathway so far, which are guideline-based. 93% have been adopted in the first 24 hours. The 7% who didn't were very early in the implementation, and so we had some learning. Our guideline adherence rate has increased 17% over the last year, and our discharge outcomes have improved by 21%. This is not because this is because the guidelines work, and because we figured out how to work it at our system. And the key performance indicators that I mentioned earlier, they're important. Look at our compliance to ventilation. Went up significantly. We were already high with our nutrition key performance indicators, so we made improvements. The CPP indicator, we didn't really make significant headway here. And I want to talk about that just to say that we didn't because the kids were really sicker than the pre-implementation time point. but the nurses documented more efforts made to actually maintain CPP. So I think there's achievement, but there's also effort that really matters. And this is nursing feedback on the pathway. They love it. They think it has reduced conflict in the ICU and has gotten everybody on the same page in terms of what are our daily goals of care. So what can we do? As practitioners, as public health providers, we can encourage guideline use. Well, first of all, I think, if the kid really has severe TBI, we need to transport them to a level 1 pediatric trauma center. We need to really develop a culture around guideline adherence, and we need to be looking forward to the 2017 guidelines that are going to be published later this year. And we do this because we care for our kids. So adherence to guidelines is cost effective and improves outcomes. And I'd like to thank the sponsors for the opportunity to actually conduct some of this research and share this information with you. Thank you very much. And I think we're going to transition to the question and answer phase. Please post your questions to the Q&A box, and then we can have a good discussion here. I just want to remind you that the talk here focused on in-hospital care. And we will be, Dr. Jamie Shandro in the afternoon is going to be talking about emergency medicine. So please post your questions to the Q&A box. The first question is, what are your recommendations for interventions for a level 2 trauma center prior to transport to a level 1? This is really a great question. And, the 2003 guidelines addressed transfer, and the recommendations were direct transfer to a pediatric trauma center. It did not really specify which level. I think that every state has their Department of Health criteria for transfer, and the Washington state, talks about critically ill children being needing to be treated not at a level 3. So I would say that if we're transporting a child to a level 1 trauma center, I think it's back to ABC. So I think we need to make sure that these kids with severe TBI are tracheally intubated. I think that's something a level 2 trauma center can do. Having 2 peripheral IVs that are functional are really critical. Sometimes we receive patients from other hospitals where there are 2 IVs that are in place, but they don't work. So ensuring that they work are functional. I think that hemodynamics, blood pressure, volume resuscitation is important. And then, choosing ventilation parameters that are associated with normocarbia, oxygenation are important. Use of hyperosmolar therapy can certainly be provided. We just have to make sure that the patients are hemodynamically stable before, during, and after mannitol administration. There's some good data showing that hypertonic saline results in better preservation of cerebral perfusion pressure. So, and in fact, national trends are suggesting that the use of hypertonic saline is more common. You can give 2% hypertonic saline through a peripheral IV, and so I think that's a very viable option for maintaining hemodynamic stability. And I think in terms of sedation and relaxation for transport, I would suggest fentanyl and midazolam, because using other kinds of agents really can cause hemodynamic instability. And I think if you're starting something and transporting a patient, fentanyl, midazolam, and use of a muscle relaxant for transport, so we're not, dislodging the tracheal tube during, would be playing it safe. And then, of course, ALS transporting mechanism to a level 1 trauma center. And then I would say we are currently working with some of our community partners at Harborview to develop these recommendations. If you're interested in what we develop, you can please contact us. and we'd be happy to be in touch as well, because I think that community centers are very interested in stabilizing patients as well, and I think that's a needed area. The second question is about, for pediatric neuroimaging, does Harborview use a quick brain MRI instead of CT? Is this something we should be moving towards? I think there are many people who feel that we should be moving towards it. Part of this is staffing and logistics and availability of this. I think if the patient is receiving an ICP monitor, then that poses a problem for MRI scanning. So there's some timing things there. There are some facilities on the East Coast who are currently studying quick brain MRI in severe pediatric traumatic brain injury. And I think the paper on that is scheduled to come out sometime soon. So I would look for a paper from Mass General to provide some information on the logistics and how that really worked. I think that if we're looking for bleed and the need to proceed to the operating room, I'm not so sure it's critical for a quick brain MRI. I think if we're looking at it as a prognosticator, then it is something that is a very good question. The next question is, what's the best tool to monitor and prevent hypoxia in the pre-hospital field in a patient with poor perfusion? This is a really good question too. So there are two parts to this. One is hypoxia, and I think that, you know, first, I think back to basics. I think we need to look at our patients and, you know, make an assessment. This may be a composite evaluation. I think that combined use of clinical examination and pulse oximetry is critical. We conducted an audit a couple of years ago of Washington State, looking at documentation of oxygenation and ventilation in the pre-hospital, arena. And in fact, documentation is not there sometimes, which makes it really hard for us to retrospectively assess how often patients are truly hypoxic during the pre-hospital period. So I think pulse oximetry standard and tidal CO2 monitoring really ought to be a critical piece of evaluating oxygenation and ventilation. At the end of the day, I think the clinician has to use their judgment to figure out if somebody's adequately oxygenated or not. So do you have a leak at the tube? Are you able to move the chest? Is the patient pink? What does the SAT say? Does the saturation waveform good? And what is the blood pressure? And I think I would say there are some emerging tools that which looks like a pulse oximeter that you put on the thenar eminence to capture perfusion to the thumb and the hand, but those are in developmental and testing phases at Harborview, looking at perfusion to muscle groups. The next question is on your 4-month-old case with an uncuffed ET tube with a leak. Do you recommend changing out with a bougie continuous ventilation to a cuffed endotracheal tube? So yes, we did that. Now, when the patient came to the operating room, we opted to proceed with the craniotomy and not change the tube beforehand because the patient was herniating. We did put some, we did try to use some gauze to sort of pack the back of the pharynx. You have to remember to take that out at the end of the procedure. And then at the end of the operation, we did change out the tube to a cuffed ET tube because we knew that that gauze was not a permanent solution. So I think if you have a child with severe TBI, yes, the best approach is to use a cuffed endotracheal tube. So there are some more questions. I have about a minute left. So I think, so the question is, how can we improve serving patients in rural areas that don't have access to trauma centers and often experience increased time after injury in accessing care? So couple of thoughts on that. One, I think bring your experts in early. If you know that you're receiving a child from the field who has severe TBI, I think there should be some trauma team activation criteria where you call your pediatric support, your anesthesiology support, your ICU support, your surgery support, etc., to meet you in the emergency department so that all decks can be on board to provide their expertise for stabilization. Second, I think we are going to be seeing increased use of telemedicine, and I think this is an opportunity for trauma centers to provide stabilizing support to rural centers in this area. And third is really calling the trauma hotline, the trauma center hotline, and asking to speak to an emergency medicine physician or clinician who's in charge, who can actually guide one through that sources of care. And then, of course, there's being familiar with the ATLS guidelines and also with the Brain Trauma Foundation guidelines, because there are excellent physicians out in the community who I think, provide fantastic stabilizing care. And I think keeping these guidelines at the forefront and having a card maybe in the ED and say, look, these are the goals, and that people can aim to achieve, would really provide a lot of support. So with that, I think I've been told that it's time to transition to the next speaker. I'm sorry I didn't get to all of the questions, but what we are going to be doing is archiving these questions, and those that we don't think we answered, we will try and respond back to you. Thank you very much for your time. I would like to take this opportunity. I think we're going to transition to the next speaker, and then I'll come back and introduce Dr. Ebel.